Thank you all for joining. Today's title is Thinking Globally About Pulmonary and Critical Care Medicine. Our first speaker is Dr. Aamer Syed. He's an associate professor in the Division of Pulmonary and Critical Care Medicine. His research focus is critical care capacity building and delivery of critical care in low and middle income areas. This includes research to improve critical care education. His work has been focused in Rwanda. He also coordinates and supports clinical exposure exchange program for Rwanda physician trainees. And in 2019, along with Dr. Hopkinson, received the VCU Presidential Research Quest Fund to study high-dose IV vitamin C as an adjunctive treatment in sepsis. We're also going to be joined by Dr. Dennis Hopkinson. He's currently a rising scholar and a hospitalist in the Department of Internal Medicine and also serves in the critical care division. He served as a U.S. Fulbright Scholar in Rwanda during the 2018-19 academic year. 80% of his time was devoted to clinical research, remainder dedicated to teaching internal medicine residents and medical students. His research focus is sepsis, improving delivery of critical care in East Africa. During the Fulbright Scholarship, he also conducted studies on acute coronary syndrome and hypertension. And in 2019, as I mentioned, along with Dr. Syed, he also received the VCU Presidential Research Quest Fund to study high-dose IV vitamin C. Dr. Hopkinson is also a co-investigator on Dr. Jackson's Chest Foundation and American Thoracic Society grant in COVID-19 and diversity. They're assessing the effect of COVID-19 on tuberculosis care in Uganda. Dr. Hopkinson's research is also funded via internal medicine funding through his position as a rising scholar in the Wright Center. Lastly, Dr. Peter Jackson is an assistant professor in the Division of Pulmonary Disease and Critical Care Medicine. His research focuses on non-communicable lung disease in low middle income countries with a focus on East Africa. Dr. Jackson first became meaningfully involved in global health during residency as a Yale Johnson & Johnson Global Health Scholar in Monrovia, Liberia. While in Liberia, he worked at the JFK Hospital, where he taught medical students and conducted several quality improvement projects. At the end of his time in Liberia, Ebola broke out in the region, and he remained involved in several nonprofits as they navigated the outbreak. In 2019, Dr. Jackson was awarded an NIH Fogarty Global Health Research Fellowship with Johns Hopkins University. During this fellowship, he lived in Uganda and conducted several research projects focused on occupational and restrictive lung disease, as well as capacity building in critical care. Recently, Dr. Jackson was awarded the first Chest Foundation and American Thoracic Society grant in COVID-19 and diversity to look at the effects of COVID-19 on tuberculosis care. Aside from his global health work, he conducts research in interstitial lung disease and sees patients in the clinic and in the ICU here at VCU. We are grateful for these speakers to share their thoughts around thinking globally about pulmonary and critical care medicine. I'm going to turn it over to Dr. Nana Simkin, who's the division chair for critical care, to provide additional commentary. Thank you all to our speakers. Look forward to an insightful discussion. Thank you.
Okay, perfect. I think I've just been unmuted. Can you all hear me now?
Yes,
Great.
thank you.
Well, thank you very much for the kind introduction. I just wanted to say a few words really on behalf of the Division of Pulmonary and Critical Care Medicine. I really cannot think of a more appropriate presentation, particularly given the last 2 years and what we've experienced with COVID and the importance of really thinking on a global scale in everything that we do, particularly in the healthcare that we deliver. So I really want to express my sincere gratitude to Aamer, Peter, and Dennis for their efforts in leading our global health programming. We recognize the importance as healthcare providers of serving our local communities, but as an institution, we really have an opportunity and frankly, a responsibility and duty to share what we learn with those outside of our immediate communities on a more global scale. The work that's to be presented today, I really believe will be a testament to their deep commitment to serving our partners around the globe. And I know I speak on behalf of the entire Division of Pulmonary and Critical Care Medicine when I say that we are so deeply appreciative and proud of your work. Aamer, Peter, and Dennis, thank you so much. And I'll turn it over to you. Thank you.
All right. I think everybody can hear me and see my slides. Is that correct? Excellent. All right. Well, first off, thank you so much, Dr. Bergman and Dr. Nanasinkum, for the kind words. Today, I'm going to be giving a presentation entitled Thinking Globally About Pulmonary and Critical Care. I have no disclosures that would give any inherent bias to the presentation, but I'm lucky to be funded by these organizations. First, I'd just like to give an overview for the talk today. I'm going to talk about global health and how pulmonary critical care fits within that. I'm then going to talk about the mission of VCU Pulmonary Critical Care Medicine's Global Health Group, and I'm going to focus on our pulmonary work. There's a number of research studies that are listed here that I've been a part of and through the VCU PCCM Global Health Group, and I'll try to touch on all of them. And then I'll also allow Dr. Syed and Dr. Hopkinson to talk about all the work they're doing in critical care, which is really impressive. And then we'll have a quick conclusion. I think when we talk about global health, it helps first to just define health. And the WHO in 1948 defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It's obviously a high bar to attain, and I don't think high-income countries have really attained it, but I think it provides a framework for what we're working towards when we talk about a healthy world. So global health is something different in that its definition needs to encompass not only health, but health in a global community. And this includes the idea of equity. I think oval one of these two kind of aspects of global health are focused on equity, the idea of equal health as well as resource allocation. The second idea I do not need to belabor in our current environment, which is issues that transcend national boundaries and require cooperative action like pandemics that do not respect borders, as we know. And finally, global health is the area of study, research, and practice that seeks to address these two issues. Whenever we talk about global health, I think we have to talk about inequity. And first, I'd just like to define health equity as the idea that there should be proportional allocation of resources to allow everyone an equal opportunity to health. That doesn't mean equal resources, it means proportional, in that some places may need more resources. There are obviously disparities that exist intra and internationally, and that often raises the question of who we should prioritize. And I think that these figures hopefully help to demonstrate why I think we should focus on global health. So both of these represent childhood mortality. And in the top map, the way these are constructed is that the size of the country represents the proportion of that disease in the world. And you can see that the United States and North America is very small, indicating that it has a very small proportion of the infant mortality worldwide. Whereas a country like Nigeria, which is the large pale green country in the middle of Africa, is one of the highest rates of infant mortality, where 6 children die for every 100 live births in 12 months. On the lower graph, you have a CDC figure that shows the infant mortality in the US, and you can see there's obvious disparities. Mississippi, which is our poorest performing state, has a rate of 8.3 deaths per 1,000 children. And in New Hampshire, the rate is 3.2 deaths. So there are obviously disparities there, but I think with a rate of 60 per 1,000 deaths in Nigeria, you can understand why it's important, if we believe in equity, to allocate resources to that country. Furthermore, I think global health training can provide a framework for us to address disparities within our own country. And so there's utility in studying it regardless. So what really drives the inequities? Well, I would say it's wealth. Health is directly related to capacity, the healthcare capacity, availability of medications, et cetera, and that's directly related to wealth. And these two maps are similar to the last one in that the proportion is represented by size of the country. And I'd like you to appreciate that they look relatively similar. And the first map shows the proportion of gross domestic product that each country represents. And the second is the share of 100-year-old people that country has within it. And you can see that in a place where I work, like Sub-Saharan Africa, it is minuscule. There are almost no 100-year-olds, and they also have very little of the gross domestic product of the world. I don't need to tell you that's because poverty leads to lack of access to clean water, lack of access to healthcare, and lack of access to medications to manage chronic disease. Global health tries to mitigate these issues through a few different approaches, and I think it's helpful to kind of frame those. So one is a horizontal approach in which we would try to improve the healthcare capacity of the entire country across the board. The next would be a vertical approach in which you focus on one disease entity. So something like Operation Smile or a malaria eradication program would be an example of this. But as we've gone forward and I've gone forward, I've found that a diagonal approach is really useful. And that's the idea that if you focus research or clinical care on one disease entity, you increase the capacity of the health system around that. So for example, I do work on COPD and restrictive lung disease, which means I had to bring pulmonary function testing to Uganda. That can be used clinically. So that's an example of a diagonal approach. In an academic global health center, and I think in an academic global health career, there's kind of an arc. And each one of these aspects is extremely important and needs to be done mindfully. But first, I think a lot of us start with clinical exchange programs. These might be short term to go and experience the healthcare system in another country and attempt to help out. This should be based upon the needs in that region, but it's an important piece, but one that's kind of the beginning. Next, you want to establish longitudinal clinical partnerships, something sustainable, where you go back to a community, gain more understanding of their needs, and ensure that you're collaborating. And lastly, I think you want to get to a place where you have collaborative, sustainable, scholarly work. And when I say scholarly work, I don't mean that you need to be doing RNA sequencing in Malawi. But what I do mean is that you should be having an outcome you're seeking to attain and measuring that. By doing this, I think we can avoid voluntourism, which is the idea that you go to a country to conduct global health work and you consume the experience as opposed to necessarily helping that community. That means you need to have needs-based projects, collaboration, and sustainability to avoid that. In doing this, I think we can change our mindset. And this has been something that I've worked through in my career, and I would challenge you to try to do yourself. Instead of thinking about global health as charity, think about the fact that these communities have a right to having an opportunity for health. Rather than thinking that we are giving aid, think about this as social justice. That's the view that everyone deserves equal economic, political, social rights, and opportunities. Rather than thinking about donations, gifts, and philanthropy, think about this as paying back. Many of these countries are resource rich, and their resources were used by high-income countries to develop some of the wealth that we have now. And lastly, rather than thinking about saviorism, where the person going to that country may think they know what it is the country needs, think about self-determination. These communities know their healthcare needs more than anything else, and they're going to be the ones to determine what those needs are. Whenever we're talking about global health, it's impossible to avoid talking about the global burden of disease studies. And their reports, there's been multiple of them, and the most recent was in 2019, and they seek to kind of frame global health through numbers of statistics. And these two maps, I think, highlight something which leads to my choice to do non-communicable disease research. If you look at mortality in the top map, you can see that the rates of deaths per 100,000 are actually not maybe as high as you would suspect in sub-Saharan Africa. But when you look at disability adjusted life years, you see that that's very, very high in sub-Saharan Africa. And that's because with a low population age and the rise of non-communicable disease, we're seeing more and more people living for a long time with disability and also dying too young. When you look at the causes of death globally, and this is a graph by the IHME, and let me explain it quickly. The size of each of these boxes is the proportion of death that disease accounts for in the world. And the darkness of the color indicates whether or not it has increased from 1990 to 2019. So for example, in low middle income countries, which is the top figure, you can see that diabetes is very dark, indicating it has increased significantly since 1990, and it accounts for a relatively large portion of death. I think the other thing to notice is that communicable disease in general has been falling, with the exception of HIV from 1990 to 2019. the deaths that are being caused by neonatal diseases, diarrhea, et cetera, are decreasing. This is the same with disability adjusted life years. I touched on this already, but this graph shows over time the proportion of disability adjusted life years caused by non-communicable disease versus communicable disease. And you can see that now in 2017, over 60% of the disability adjusted life years were due to non-communicable disease. The top 4 non-communicable diseases account for 72% of all deaths. And those top 4 are cardiovascular disease, cancer, diabetes, and chronic respiratory disease. And chronic respiratory disease is particularly worrisome because it has increased in prevalence so greatly over about 20 years. So on the left, you can see in 1990, chronic respiratory disease was the 6th leading cause of death, and it is now the 3rd. Meanwhile, a lot of our communicable diseases have again dropped as far as the proportion of death they cause. There are multiple risk factors in low middle income countries for chronic respiratory disease. I could give an entire lecture on that, but I'm just going to say that that is true. And non-communicable disease are challenging because they require a spectrum of care. They require preventative outpatient care, as we know, but they also require intensive care. Critical care in low middle income countries is particularly challenging. And Dr. Syed and Dr. Hopkinson know more about this than I, and they'll talk a lot about it, but I wanted to give an introduction. Low middle income countries average about 0.1 to 2.5 ICU beds per 100,000 compared to 25 per 100,000 in the US and Europe. ICU care in high income countries is very expensive, as we know. That cost is lower in lower income countries, $109 a day in a study in India, $100 to $1,500 a day in Uganda. But when you look at the proportion of an average income that entails, you realize that it is not attainable. In Uganda, for example, a day in the ICU could represent 91% to 1,363% of a monthly salary. ICU care and ICU research is difficult in low middle income countries because there's poor epidemiologic data. It's likely that ICU needs are underestimated because many people who are critically ill due to lack of emergency medical transport services will not make it to an ICU to be counted. Many of the guidelines we develop for critical care are disregarded in low-income countries because they lack some of the resources necessary to implement them, and they may kind of throw the baby out with the bathwater. So it requires locally tailored guidelines. Finally, the best practices in low middle income countries may not be what they are in high income countries. There's been numerous studies looking at fluid resuscitation and sepsis in sub-Saharan Africa, both in children and in adults, that have shown that 30 cc's per kilo leads to increased mortality in those communities. So it requires ICU research in those settings, which is why Dr. Syed and Dr. Hopkinson are devoted to that. I won't talk too much about these, but just to make people aware of the Sustainable Development Goals by the WHO that address everything I'm talking about. So they have a goal to decrease communicable diseases, 3.3, decrease non-communicable diseases, 3.4, and a number of other goals. It's worth looking at if you're getting involved. So now I'm going to talk more about my actual work. And first, I'd like to give you a little context about where it is that I work. My primary site is in Kampala, Uganda. It's a low-income country in Eastern Africa with a yearly income of $780. It has a high rate of HIV/TB co-infection and very high rates of domestic indoor air pollution from cook stoves, as well as ambient air pollution. It's the 15th most polluted city in the country, and the annual particulate matter is over 10 times that in Los Angeles. I do a lot of work at Malago Hospital and the Makerere Lung Institute, which is pictured below. And they're really important in how my work gets done. I also have done a bit of work in Haiti, and I'll touch upon it. People are pretty familiar with Haiti, but suffice it to say they have a severe lack of ICU resources and a lot of challenges to care, both political and environmental. So I think challenges, you can talk about them, but I think pictures may do better. So this is a picture of the tuberculosis clinic on the left in Uganda. And you can imagine a chart review would be pretty difficult in a place like that. Whenever you need to implement a test or equipment, you end up with broken pieces. This is a regulator for me trying to do pulmonary function testing that did not fit the tank. And I can't go to eBay and just get one. So that makes a real challenge. And lastly, you end up having to do things you wouldn't. This is my friend Trishul and I moving an oxygen tank to try to do bronchoscopy in Uganda. And, you know, lucky for me, usually at VCU, I don't have to do that. So the VCU Pulmonary Critical Care Global Health Program has sort of three aims. One is education. So we have a number of different education projects, some of which are listed here. Research, we have a number of those as well, and those are listed here, and I'm going to try to talk about a lot of them. And then the other aim is capacity building. And as I talked about with diagonal approaches, I believe that all of the work above increases both human resources within those countries by developing expertise through education, and by increasing the healthcare system around the research projects we do, we increase the healthcare capacity. So to talk about some of the research projects, I thought I'd start with a case. This was a person I saw in Uganda when I was living there. It's a 73-year-old man. He came to see me at the Lung Institute. He had shortness of breath for 20 years. He lives in Karamoja, which is right near the border of Sudan in the north. It's extremely rural. And he's been exposed to cook fires his entire life. And this is a picture that I took inside somebody's home near Karamoja. You can see the smoke within the air. And this is a cook fire. They're burning wood. And that particulate matter has been breathed in by this person his whole life. Biomass fuel is very common. 80% of the world uses it for cooking and heating. And so this exposure is extremely common and leads to a lot of lung issues. His vital signs showed hypoxemia, his exam had wheezing, and his chest x-ray showed hyperinflation, all consistent with COPD, and particularly biomass-associated COPD, which is actually the most common type of COPD worldwide. Some of the work my group has done previously shows that COPD and asthma rates are high in low middle income countries. This was a cross-sectional population-based cohort study where my colleague, Dr. Siddharthan, went door to door doing pulmonary function tests on anybody who would say they'll do them. And he had 1,500 participants and found that 6.1% of people had COPD and 9.7% in urban areas had asthma. There was also a very high rate of restrictive lung disease, which is RSP, which is a particular area of focus of mine that I won't be able to touch on today. Treating COPD is a challenge in these settings. I don't think you'd be surprised to hear that. If you look at the far right column, this was a study where we looked at availability of inhalers in 3 different sites in Nepal, Peru, and Uganda. But there are no inhaled medications with the exception of albuterol, or a short-acting beta agonist in Uganda, and only 79% of pharmacies have those. Furthermore, these medications are not affordable. The cost for asthma treatment ranges from 0.47 to 1.75 days of wages, and the treatment for severe COPD is even more, up to 2 months of wages in Uganda. So how do you improve care for biomass COPD? Well, Dr. Siddharthan and I, he's the lead on this study, I'm a co-investigator, developed a randomized controlled trial looking at low-dose theophylline. Theophylline was used in the past to treat COPD, and it's extremely available in these countries and very cheap. Low-dose theophylline is very safe at 250 milligrams of extended release per day. And there's reason to believe it may even be more effective given some of the inflammatory milieu that we see in biomass-associated COPD. This randomized controlled trial has recruited 65 patients. Our goal is 100. And analysis is yet to come. I'm going to talk a little bit about some of my healthcare delivery research now. A lot of this is related to tuberculosis, and tuberculosis is a perennial pandemic. It kills 1.4 million people yearly, and it infects 9.96 million people yearly. And you can see that it is highest in low and middle income countries. So why does TB kill? Well, the percent cure for tuberculosis when treated promptly is about 80%, even higher in some studies. And you can see the percent cure is relatively good when you look at the map. However, there are many deaths. And the reason why is when you look at the number of people who are put on treatment, that is this map, promptly, it is very low in places like sub-Saharan Africa. And that delay in treatment leads to increases in mortality. So knowing this, I became very concerned when COVID came along. And having worked in the Ugandan TB clinic, I knew how fragile the delivery of that care was. And so one study came out and said that they predicted that COVID-19 may cause 6.3 million excess cases and 1.3 million excess deaths from TB globally over 5 years. The majority will occur in low middle income countries. And so I looked at some of the data from Uganda, and I saw this precipitous drop in the number of people diagnosed during the lockdown, which was April to June, the yellow bars here on the graph. And then it didn't improve back to the previous rates in diagnosis, treatment, or even those admitted with TB, which really raises the question of what's happening to those people that are not showing up. So we were able to write a grant to the CHEST and ATS Foundation to examine this, and it's a retrospective chart review where we look at 1,500 charts. It takes quite a bit of effort. There's 6 sites, and we have urban and rural settings, and we identify those people and have phone calls with in-depth interviews about delays to care, barriers to care, and then we also have in-depth, semi-structured qualitative interviews that are going to be conducted later. The study has these sites. You can see them sort of dotted here throughout Uganda. 3 of them are very rural. And we're collecting data. We finished 5 of the 6 sites, and the plan is for completion this month, and then in-depth interviews will follow. There's also the ability to have translational research. And when I was in Uganda, I took care of this girl, and she was an 18-year-old who came across the border from Congo who had previously been treated for tuberculosis. And it's hard to see, but hey, it's hard to read CT scans in Uganda as well. This is a film CT, but if you can look at the left lower lobe, you may notice that there's a ton of fibrosis and almost complete destruction. And that's termed post-TB lung injury or lung impairment. It can happen in up to 50% of people who have microbiologic cure, and it causes a decrease in pulmonary function, decreased quality of life, and an increase in mortality. There's been very little research as to why this occurs. And the thought is likely that there's an imbalance between inflammation and resolution. So rather than the injury being tuberculosis infection being followed by resolution, you have ongoing inflammation that leads to scarring and permanent disease. Dr. Syed, who is an expert in inflammation and resolution, does work with a molecule called specialized pro-resolving mediators. And as I was kind of listening to her work, being involved in her lab, I realized that this may be a key to unlocking why post-TB lung impairment can happen. So specialized pro-resolving mediators are lipid molecules. They are derived from the arachidonic acid pathway, but they're dysregulated in several diseases: COPD, pulmonary fibrosis, asthma. And our hypothesis was that in TB infected people, you have the initial insult, and then a dysregulation in these specialized pro-resolving mediators may ultimately lead to the development of persistent lung injury. We wrote a grant for the Pulmonary Fibrosis Foundation, which was recently funded, and it will allow us to determine those at highest risk of post-TB lung injury, and to create a biobank of exhaled breath, which is a surrogate for lung lining fluid, and blood to examine this more fully. I won't go too much into the study here, but it will be able to retrospectively get those samples. So we'll be able to look at people who are diagnosed at the time of diagnosis and see if that predicts their ultimate outcome. We also have projects in education and capacity building. In January, I was able to go to Haiti and conduct a training for non-invasive ventilation. Non-invasive ventilation is an important aspect of care here in the United States, as we know. It involves application of positive pressure to assist with oxygenation. It's a standard of care and has a mortality benefit in COPD and acute pulmonary edema from CHF, both of which are on the rise in low middle income countries. And it has a likely benefit for COVID-19 pneumonia. There's a conditional WHO recommendation, and possible benefit in pneumonia and immunocompromised hosts, such as those with HIV. Despite a lot of need in low middle income countries, it's rarely available. And that's largely due to training and availability of machines. So some of my colleagues in University of Miami were contacted by the Department of Health in Haiti and Bernard Mebs Hospital, which is in Port-au-Prince. And they partnered with an NGO to form a multidisciplinary team and create a curriculum that involved simulation as well as didactics to teach non-invasive ventilation. The primary outcome was improvement in confidence on a 5-point Likert scale and improvement in knowledge on post-training exam. And you can see that in 36 trainees from every district across Haiti, we had a significant improvement in the confidence using non-invasive ventilation and in the knowledge of non-invasive ventilation. And these tests were based upon CME content. So these were really difficult tests to take, and we saw a really notable improvement. The last project I'm just going to touch on is the bronchoscopy implementation project that we did in Uganda. And we were able to create the first clinical bronchoscopy training program in that country. This was through partnership with Johns Hopkins, grants from the Chest Foundation, and donations from Northwestern and Johns Hopkins of supplies. But you can see in the top left, this is the bronchoscopy suite when I arrived in Uganda 2 days after I arrived in September. And in a week, we were able to set up all of these materials. This is a TV I had to take out of a dorm room to connect to the bronchoscope, but it worked. And through training, which you can see the training program we had there, the final picture is the day where I stayed and I was observing all of these bronchoscopies. And on the last, one of the last cases, I did not touch the scope and I did not have to direct the team at all. And that was the day where that group, which includes an anesthesiologist, nurses, Bruce Chiringa and Wincy Katagera, who are at the McRae Lung Institute, performed a successful bronchoscopy. We were able to write this up, and then we also were able to evaluate the cost effectiveness of this. So, you know, I think hopefully this just highlights the range of research you can do. I just want to thank everybody who works with me. And I also just want to turn it over to Dr. Syed.
Thank you, Peter, for the excellent talk and the segue into our talk. I'm going to pull up my screen. Dr. Bergman, you can see my screen, right?
We see that you started, there we go. Yep, it's up on the screen now.
All right. So Dennis Hopkinson, who's at Duke currently doing his pulmonary critical care fellowship, may not be able to join us. He's on the lung transplant inpatient service. So apparently they're very busy, but he may join in the midst of all of this. But this is something that he led me on to about this quote, only mountains cannot meet, but people can. And it's been used in several cultures that people can get together and solve problems. So this is what we want to really kind of focus on, the critical care work that we've been doing in Rwanda. To change my slide. There we go. All right. So we're basically, I'm going to touch upon these topics. And the reason why Peter and I kind of thought it would be a good idea to do this is not just talk about the work that we're doing, is also kind of spark interest that everybody else in our department or at our institution can do. And that's really the purpose of this talk, I think, in my opinion, is we all need to be doing work. It could be globally in Rwanda or Uganda or in the US itself, as a lot of issues that can be solved. So basically, why do global health? We're going to talk briefly about our work in Rwanda, education and research. Those are the two primary areas. We'd like to touch upon briefly the state of global health at VCU and how many partners are already doing work. But again, there's no cohesiveness in that. And then the future directions and how you all can get involved. So like Peter so eloquently pointed out, it's really a health disparities issue, right? It is how we can start to address those, how we can actually start to recognize those in the world around us as well. In my other world, in my pulmonary world, I do sarcoid. And every time I see a patient with fibrotic disease, I wonder if it is just lack of access to healthcare. That's why it's fibrotic, right? So it happens, or in the ICUs, we see DKAs come in all the time, or hypertensive emergencies. That's a health disparities issues, I think, right? So that is something that we can address, or at least start to think about. It also makes us better doctors when we work in a resource-limited environments. And then there's opportunity to build capacity and help improve healthcare delivery, which is a big part of what we need to be doing. Training is a big part on both sides. We can learn from low resource environments as well, and then we can share knowledge. And then while we're doing all of that, the research opportunities that help guide future projects and future mechanisms of delivery of care become important. So very briefly about Rwanda, it has an interesting history, and it's still most recently in the news as well. It's only a population of 12 million people, with 80% of the population under age 35. Okay, most of them are farmers. Average household income is only $500 a year. So very poor country, right? And in the genocide in 1994, and this is remarkable if you put things in context, it was a million people were killed in a matter of days, right? 20% of the population at that time. And that always still surprises me is when you go and work there, it's like how young everybody is, because of the number of people that died during that time, right? So after genocide, extremely poor situation. But in the last 20 years, there has been like enormous improvement, right? Life expectancy at birth in year 2000 was only 48. And in 2016, in just 16 years, it's 67. This is probably one of the few countries in the world that has seen such a remarkable change and improvement. So it goes to show that how much can be done in a very short time when there's a will to do it. There are partnerships that are formed that can make this happen. AIDS-related mortality, right? In year 2000 was 273 in 100,000 people. In 2012, it was only 49. Right? So there's a lot of focus on public health policy. And ironically, this COVID pandemic highlights our deficiencies in public health policy, right? The structure is there, the desire is there, but delivery of public health policy is limited or constrained by various issues. But that's what makes this large, impactful change. There've been a lot of development partners too, and it's all about partnerships. There's a lot of governments, fundraisers, and various academic institutions have been involved, including NGOs in Rwanda, to kind of make all these big changes. So, as Peter also alluded to this, is when we go into these environments, it's not like what we think we want for them. It's the question we have to ask is, what do you guys need and how we can help you with, right? So this is something that we've been involved in Rwanda since 2018. And so what we've identified through various discussions, time on ground, is these three large areas. And there are many more, but this is what we've thought that we could help with, right? So one is education and training, and this is all kind of related to acute care or critical care. So we'll expand a little bit into all of these, but each of them is a separate topic by itself. But the FCCS course, it's a Foundations of Critical Care support course that is run by the SCCM. We thought that would be a good place to start. And then with UVA, we have a Rwandan trainee rotation exchange program that Rwandan anesthesia residents come out. And then the next project we're working on, critical care training programs. Then other need was sepsis. And I'll tell you why this is such a big problem based on the work done by Dennis and myself and other collaborators as well. So with that, we have a couple projects going on, sepsis study. So basically to study epidemiology, presentation of sepsis, and then how what we can do to make structural changes to improve that, which is, as a feasibility trial, we'll talk about the vitamin C trial in a little bit as well. So the state of healthcare in Rwanda, right? Again, as it was pointed out before, there's 0.1 physician per 1,000. The WHO has a recommendation that it should be at least 2.5 or as such. So way below. In comparison, look at what the US has, right? So it's 2.6 physicians per 1,000, but Boston has 4.5 per 1,000. Cuba, which has done enormous work with their public health policy and public health delivery mechanisms, has 8.4 physicians per 1,000 as well. So that is the highest in the world. But anyway, so Rwanda has 4 referral hospitals for a population of 12 million. There are only 24 ICU beds. And you can imagine, and again, Peter pointed this out the other day, in our critical care tower, we have more ICU beds. Actually, one floor has more ICU beds. We have 28 ICU beds in the MRICU on just C4, right? So this is a population of 12 million has 24 ICU beds, and there's no critical care training or trained physicians. And this was the work which we really kind of set the things in motion for us is, and this started in 2018 when Dennis was there. And it took a while getting this done. And we were finally, after much struggles, were able to publish it just recently. The study showed that in-hospital mortality from sepsis is 51%. But ICU mortality from shock is 83%. And that is as dramatic as can be, right? So that got us thinking like, hey, what can we do in this situation that maybe small interventions, it doesn't have to be large interventions, can we actually make a difference? Because these numbers are just horrendous. So this is kind of just getting into a little bit detail about the education and training component in Rwanda, right? So it's a very, very ambitious agenda we have set out. And part of it is having this talk is we need partners. We need partners at every level from across the system here at VCU as a start. But as in the picture that I have up there with his back with a check shirt on is Kwame, who's is a nurse practitioner in the surgical ICU here at VCU. He's been one of my mentors, my inspiration in getting a lot of this stuff done. He's the lead NP up there. He also holds a position at UVA as a clinical instructor, instructor there as well. So we hashed this plan back there, like, you know, let's take this FCCS course that's a prepackaged set of slide deck and go and teach it there, you know, just run it there. So it's essentially a course for non-intensivists to manage critically ill patients, the first responders essentially. And then the next year we said, yeah, this is great. Everybody loved it. And then we thought, okay, we should make it sustainable. Then we start training trainers there, right? But while we're doing all of this, and this is where the subtleties come into it, is this course is just not applicable to that environment at all. But you don't get that feedback from the locals because they're like, you know, they are incredibly, at least in Rwanda, they're very polite and they will never say, you know what, I know this doesn't have any meaning. And this course talks about getting blood gases every 2 minutes or doing some sort of thing. And it's like, there's not a single ABG machine, or there's one ABG machine in some hospital that is in a cabinet somewhere tangled up because there are no supplies, right? So that led to, and we'll talk about how that led to improvement in how we're going to change our education delivery as well. So that's one piece. Part of that is running in parallel, and UVA has done a fantastic job of supporting the anesthesia residents, but they lack critical care training. So again, in 2018, we partnered up with them so that Rwandan residents come out to the US, spend a couple weeks or 4 weeks in UVA, and then spend 2 to 4 weeks with us. As some of my faculty have very kindly let the Rwandan residents rotate or at least shadow them. And this is all done on a shoestring. If you talk about where does the money come from, a lot of it comes from personal funds. And this is where VCU and VCU's, administration management needs to think about why this becomes a important part in helping support these projects. We're also talking about, Dr. Nanasingham and Dr. Simon have been fantastic about supporting all these projects. And there's talk about maybe potentially having US trainee rotations in Rwanda, because really that's a huge component of education that I think we miss. The big project that is kind of underway already is critical care training. So one of the needs that has come from, especially COVID has pushed things along quite a bit, is the Rwandans have said, listen, with COVID, we have realized we really need to speed up this critical care education part of it and maybe look at fellowships as well. So we've been in discussion with the Rwandan Health Ministry for quite some time now. And most recently, it's taken on a sense of urgency. UVA has a lot of experience in setting up their residency program for anesthesia. So they've partnered up with us, and Anna Crawford at Harvard with us has kind of at least taken a stab at writing a critical care curriculum. And this is just planning stages. Again, this is also for us marketing, saying, hey guys, if you're interested, you're welcome to join. It's select core faculty in the US for short rotations, because one thing that we realized, while there is didactic virtual training that can be done, which I think this style has a huge role, the translation of the information is where I think our residency programs or training programs provide, right? We can read from a book. I mean, they have access to internet and they can read from books as well, the Rwandans. But when you come down to translating, and there are tons of examples, I mean, they know all about ARDS and they know all about low tidal volume ventilation. But when you say, hey, how do you dial in this thing on the ventilator? How do you, think about lung compliance? It's a complete disconnect, right? So that is where I think that component of bedside teaching becomes important, and that's what they want. The Clinton Foundation had a big project for years. It's called HRH program, the Humans for Human Resource for Health. That would turn out to be a very expensive project where they actually paid US salaries for US faculty to go out and spend 6 months at a time, or a couple months at a time. And they would practice US medicine in Rwanda, which really had its growing pains, was not efficient, had some disastrous consequences at times. But we tend to repeat these things over and over again, is where we think we know what's best for them. But anyway, so running through, I'll be mindful of our time, getting quickly through our projects. So our first study that we started was a sepsis study. Is basically, where are these patients presenting from? What are the sources? How it's managed, and what are the outcomes, right? So this was a retrospective study. As you can see, there's a picture of our chart, and some of us may remember it. That's how we wrote notes. It was really nice because medical students, I wrote notes, and the resident just signed off saying agree with above. So that was really nice for the residents. But anyway, so the paper charts were reviewed by the Rwandan students. And again, this is the study that informed us that ICU mortality from shock is 83%. Give me 1 second, my screen disappeared. There we go. So then that led to, and the FCCS course that I talked about, and realizing it's truly not the right course for the population. And since it's a product of the SCCM, we just can't change it the way we wanted to. So that led to this ICU best practices. And actually, Peter helped us on this as well, is to kind of develop some research questions. So the question was okay, a lot of people are dying. Why are they dying? What are the structural issues? So we are actually, this is actively ongoing. We have 4 data collectors, prospective collecting data 24/7 really per ICU for 6 weeks. And the thing that they're charting is they just sit there with a sheet that we made for them, and they will document, what are the ICU resources, how many ventilators there, how many, how frequent the labs are being done, do they have imaging available, and then the referral patterns, where these patients coming from, and the current ICU practices, which is huge, I think, is what antibiotic choices, because and probably Gonzalo Behrman and Mike Stevens, if they're on it, they already know this problem is drug resistance. Meropenem is first choice. When you walk into the ICU, someone comes in with some abdominal infection, meropenem, right? It's the first thing that rolls off their tongues. So it's a scary thought, but we were just documenting, saying what the choices are, what the reasons are, what kind of sedation protocol, what kind of ventilator management, stuff like that, so that we can at least educate ourselves before we go and say this is what needs to be done. And the goal of this is to actually develop future ICU guidelines that are tailored to the local environment. And then finally, the other last research project we have is this high dose vitamin C in sepsis. Like we said, mortality is very high. And this was hashed in 2018, and, vitamin C, plus or minus, does it work, not work? A lot of controversies, even in the US, with papers coming out with different findings. But for us, what we thought was, it is non-toxic, it may help, but our true goal is, can we actually do a randomized control trial in a country that's really never been done in a critical care setting, right? So if it is possible, then what are the challenges? And then while we're doing that, why don't we check a few numbers and look at some secondary findings? And this is how our safety trial that Barry Fowler, who mentored me in this study initially years ago, this is how we set it up. We had 24 patients, 12, did standard care, and 12 went to standard care plus vitamin C. And the idea is really, can we even do this? Can we take the drug, put it in via IV into their arms? And then we'll study what the other potential outcomes are. But now this is where it is incredibly interesting, and I don't know what the outcomes are going to be. First of all, the concept of placebo met with a lot of consternation. And they're like, what do you mean? You're not going to give us the actual drug? You're going to give us a fake drug? I don't think we'll accept it, right? Then the concept of informed consent, that even the doctor's saying, why do you need informed consent? If you're going to do it, just do it, right? I mean, we don't have to tell them whether they're going to get placebo or not. Let's just give them drugs. So these are all questions that are coming up. And these are hopefully by the time we're done with this. So this is actually underway currently. COVID put a big damper on it. But so it brings up all sorts of ethical questions, all sorts of how we're going to do this study. So more to come on this. All right. Very quickly, I'll move on to the global health landscape at VCU. So access is acute care and systems strengthening. It's a longitudinal elective at the medical school. And so we in the medical school, the M2s, the four M2s really ran this project with just minimal supervision or guidance from me. They conducted a system-wide survey, and you can check this link out. It's actually pretty amazing. So all faculty responded, and 74 faculty are involved in global health at various parts of the world. And this is the map that they kind of produced. And the names, the areas that they're doing work in is all listed on the School of Medicine website. So it's fascinating work, and it's shocking that there's so many people involved, and mostly a lot of them are in the surgery department, right? So we should know about this and share information that we could potentially collaborate. So like I said, very quickly, kind of closing out my talk, the Global Health of VCU, the future directions, we hope to establish formal exchange programs, maybe a pulmonology critical care program. Global surgery, I mean, surgery is already doing it. They sent a global surgery fellow out a couple of years ago. But again, it's all predicated on funding. And my mentor in Rwanda, Pauline Banguti, he's an anesthesiologist, chief of anesthesia. He's the one kind of helping us guide from the Rwandan side, from the health ministry side, as to what their needs are and how we can meet up in the middle and support them. Again, and Pete, I think this is Peter's prime desire, is to have a VCU Global Health Office, a center, right, that can coordinate all of this, because this is where, I mean, we're doing everything on a shoestring. We're pitching in money from our own pockets to get this stuff done. UVA has a center of global health, and that's a model that exists. we may not have the endowments that we do, but that's something that is still possible because this is important work. Lastly, I'll touch upon, not to take any more, I'll just take probably a minute to finish out this, is preparation for global health work. And this is what is an important part is understanding that, there's no standardized training that exists, right? Peter, Dennis, there are some courses here that are starting to teach the students and the residents as to kind of understand what it takes to get into this so that we don't show up and start telling people what to do. But so there's no standardized training, but we all kind of learn, this FCCS course, right? We go there, we are really happy, pat us up on the back for 4 days, like, wow, we did an amazing job. And it was not applicable at all, right? So that is something that I think we need to understand better before jumping into this. There are some systems already exist. The medical school with the Access program, and Dr. Rodas, who's a surgery trauma surgeon, who's done an amazing job, and the Access students run a fantastic program. So the medical students are getting this education. The global health disparities, internal medicine, that Mike Stevens and now Sarga runs it. I don't know the current status of that, but there's an avenue. If it is not active, I think that needs to be kind of reactivated, because I think this is very important. But in other words, what we're asking is we need help in all areas. This is important work. It could be exchange, research, teaching, or even admin work. So we need you all to be involved in all of this. So thank you for your time, and really think health disparities is the prime driver for all of this. And I will stop sharing. Thank you. We're open for questions.
Thank you all so much. Appreciate it. I put some contact information in the chat box, as well as links to both the VCU School of Medicine link, as well as the Pulmonary Global Health. So we'll open it up for questions. If folks have comments or questions, you can use the chat, the Q&A, or just ask to be unmuted. We're happy to unmute you. Thanks.
As we're waiting for questions and just kind of closing, I'll just quickly say, people often ask kind of what projects could be global health. And I would just tell you that anything can be global health. So if you guys have projects that are interesting, again, just reaffirming, we really want you to reach out. It's really anything that is important scientific work and sparks joy and has the needs of your community is great. So, please, if you don't have questions right now, please just reach out to us.
Excellent.
Looks like we got one question here in the chat from Christine. Who should we contact to get involved with Global Health Research Project if there's no department that coordinates them? Any thoughts?
Well, I would say that I think we are trying to sort of form that department. Aamer he kind of displayed my deepest wishes and dreams at the end about having a global health center, but I do think we are working towards that. And so, Aamer and I are both co-directors of the Pulmonary Critical Care Global Health Group, and we can help, I think, direct at least to some of the other resources if it's not necessarily a pulmonary or critical care project. But I think we've learned a lot about how to do these projects in general. So, I'm always open. And Dr. Rodas is another, very accomplished and experienced person in global health. He's a great resource for anything surgical. But, we're all happy to talk.
And yeah, absolutely. And like Christian put it on the link up there, there's the med school link. So the recent survey, and this is really hot off the press, there's a link to the survey. It has emails of all the faculty who are doing work, and it's just not in School of Medicine. We've actually had School of Engineering, pharmacy, physical therapy, nursing, all kind of sign up. So there's a list of faculty and their areas that they're interested in or work that they're doing. So that's a good resource if that interests you, or either one of us can direct you. So there are several ways of doing it, and yeah, thanks for posting that. So that's a great link if you want to start off with, and that's a first stab really at forming this. Excellent.
Thank you so much for highlighting global health. Very helpful and thought-provoking conversation. So thank you. Dr. Syme, any closing comments or thoughts?
No, I just really wanted to share our thanks to you for taking on a globally important set of problems. You know, we're very privileged in the lives we live here, and it's, I think, important for us to be able to share and to listen to what the needs really are of other. Thank you. Thanks for your commitment.
Thank you all. Thomas, if we can put up the CME code, there it is in the chat box for folks. And again, thanks to our speakers, Dr. Peter Jackson, Dr. Aamer Syed, as well as Dennis Hopkinson, who is busy on the transplant floor right now doing important work. So I'm sorry he missed things, but he would be glad to talk to anybody who is interested, I'm sure. So thank you all so much for your time and dedication. We really appreciate it. We'll leave the room open for a little bit to make sure people have the phone number and code for the CME. Thanks, everyone.